Nasser Said, could you run the video, please? Could you run the video? ممكن تمشوا فيديو؟ ممكن تشغل الفيديو؟ Well, welcome to the session about new technologies and innovations in the field of diabetic foot. I would like to thank Professor Nasser Said and the organizing committee for allowing me to organize this session. And I would like to welcome our distinguished foreign guests, Dr. Alexander Lazarov and Dr. Giacomo Clerici from Italy, and our national faculty, Dr. Ihab Nabil from the National Institute of Diabetes and Endocrinology, and Dr. Fadi Mshil from Ain Shams University. Please, Dr. Ihab Nabil, come to the podium. And I would like to call our co-chairpersons, Professor Ahmed Hassin, Professor Gabriel Pifaretti from Italy, Professor Hussam Tawfiq, and Professor Walid El-Baz. Please come to the podium. And now we could start. I would like to introduce Dr. Alexander Lazarov. He's from Bulgaria. He teaches the philosophy of artificial intelligence in Sofia University. Please.
Thank you. Okay. Good morning, ladies and gentlemen. Let me first thank Professor Nasser Al-Said and Professor Bishara for granting me the chance to deliver a presentation before you today, and for their braveness to involve a purely non-medical person to a medical event. We are experiencing an interdisciplinary era. So I'm about to comment on artificial intelligence that is already in play now in this very moment. You can reach it both with your smartphones and various other devices. It is available in human-supervised and non-supervised versions, and it's named narrow artificial intelligence. Narrow means very, very highly specialized. So my target today is to bring you some basic awareness on its nature and its principles of operation, as to encourage you to employ it. And I hope that some 10 minutes ahead, every one of you could make an assessment whether this is some new type of our instrumentation, our assistant and partner, our collaborator, an opponent, a competitor, the set of all that, or something else. And besides, you'll know why philosophy is involved to all that. I will start with the diversity between robots and AI because perhaps due to science fiction, people immediately relate AI to robots, but that's just partially true. Robots are, in fact, computer systems periphery. They only perform or transform what AI has generated. And to better understand that, the robot is just the actor, while AI is the scriptwriter, the command center. And if dedicated to speech recognition, to medical diagnostics, to language interpretation, AI does not at all need a robot. It only needs a display or a network to present you what it has generated. Now let's spare a minute for the digital bit. All of you know that these are long lines of sets of zeros and ones. One signifies yes and zero encodes no to a certain question. But attention please, here is a question. So there is a philosophical query. Who or which was the agency that has raised that question? And besides, who and how detected the answer and made the assessment of whether it is a positive or a negative one? In the case of medical diagnostics AI, this means that you should always bear in mind who has developed this algorithm. Was there any medical expertise involved to its creation, or at least to its certification? Now, apparently, as you read about AI, you always meet a triple term that says deep learning of big data via neural networks. The neural networks are a specific type of hardware, of processing unit, and I will skip commenting on that due to the time frame. But the big data and deep learning are a really challenging phenomena. It has three typical features. The first one is shown in its name is being big. These are enormous, tremendous lines of data that no human can ever memorize, detect, consider, think about. Well, the computers already can do that. Besides, big data is characterized by the fact that these are real-time data streams. They are not structured, they are not memorized. And finally, a big data set in any event involves at least two flows having heterogeneous origin. A minute ahead, you'll know why. So here comes the logical question: what is intelligence and can it be artificial? There are a lot of narratives on what is intelligence suggested by both philosophy and psychology, and yet there is no agreeable one. However, once commenting on artificial intelligence, in any event we have in mind its capacity to autonomously generate successful predictions. And successful means that these predictions really happen on a time horizon ahead, and autonomously is just the opposite of externally driven. So, as we are commenting on prognostic capacities, let's think about how we humans create our hypotheses. We involve what we have in our memory, I mean knowledge accumulated either by theory or by experience. Thus we know physical laws and some principles of social behavior. We involve logic and we have an outcome. Classical computers can do the same because any rule, any law can be presented either as a function, either as an equation, and then it applies mathematical logic and statistical methods. Careful, statistics means that your patients in medical diagnostics are treated as entities, not as subjects. However, apparent AI solutions can do something in addition that we cannot manage. By observing the big data sets, the streams, if it finds out digital patterns which represent either correlations or interactions or process development stages, it determines them. And for example, if there are stages A, B, C, D, E in the first flow and common similar phases A, B, C, D in the second one, then AI immediately concludes that there will emerge an E phase in the second flow. Importantly, it cannot find out the cause-event line. It cannot tell you why this will happen. Yet, its forecasts are successful and it calculates the probability of this event happening. It is very essential here to say that the ABCD example is a very simple one, but there are cases when in the one flow there are detected 900 stages, in the other one 890 common events, so the probability is highly raised immediately, and besides you know not just a single step ahead, but 10. So this is the intelligent procedure. The time frame does not allow me to get in detail here. Please remember that it is a four-step line which is more or less common and similar between humans and AI. And this is my last slide, and this is the very essential one. Now, if you create an idea, you have an idea, it is purely yours, and it is absolutely under your control and your will whether to make it accessible to others or to keep it in privacy, in your memory. If you decide to make it accessible to others, you have two options. Either to perform it virtually, that means you tell it to someone, you deliver a presentation, you write a book, you make a piece of art or whatever. Importantly, the performance does never cause any consequences in the physical and social environment. It is just a data exchange. But also importantly, there must be involved at least a second intelligent body to perceive the appeal. A performance with no audience, a book that is not read, is a nonsense. It is just the opposite with the transforms. If my idea is to break this door, I take a big hammer, I push it, it breaks into pieces, and there is no matter whether somebody has watched me or not. Now, how is this related to AI? This is the so-called black box phenomenon. AI creates a lot of production, and we cannot observe neither the data input nor the data processing stages because big data is involved and we cannot manage it. So we are in a blind, passive position to be presented what it generated. And what I can suggest, and it is generally recommended, once dealing with AI, we must ask as many questions as possible. We must make as many simulations and tests as possible just to get ensured that we have squeezed out the very maximum of its production. Thanks for your attention.
Thank you very much for a very interesting presentation. We need to know a lot more about artificial intelligence. Now, I would like to present my colleague, Dr. Ihab Nabil, who is the Dean of the National Institute of Diabetes and Endocrinology. He's going to talk about a new aspect of wound care, and that is ventilation and weaning from VAC. Dr. Ihab.
Good morning, Mr. Chairman. Good morning, dear professors. I would like to start by thanking Dr. Nasser Said for the excellent and outstanding preparation for such a beloved meeting that we all care to attend. The title of my presentation is Ventilation and Weaning from Vacuum. Yes, indeed, I mean ventilation because in wound care management, in cardiac surgeons, they consider ventilation in open heart surgeries, long surgeries. They ventilate the wound itself by carbon dioxide to limit the infection at all days. And also, knowing the vacuum as a weapon to salvage our limbs is very important, and it's important to know when to stop it and wean the patient from the vacuum usage. In fact, limb salvage is as important as life salvage, but comes next after the life salvage. We have to mix and match and create all our master scene. In case we have a very unsalvageable feet with severe infection, peripheral arterial occlusive disease, diabetic, in presence of infection and raised serum creat, we are obliged first to debride and clean our wounds prior to start with angioplasty for such patients. Such a debridement would end in a very dangerous wound that needs salvageability. This salvageability could occur by first revascularization, and full revascularization should be attempted as much as possible. I won't go through this, but yet the advancement and the technologies help much in wires and in revascularization techniques to achieve full revascularization distal as possible to achieve adequate blood ample supply. Then we opt for going for a vacuum treatment. Vacuum treatment could go endlessly, but we should be very judgeful not to jeopardize the limb by excessive usage and excessive moisture or in presence of infection. So the guidelines ensures not more than 4 weeks usage of vacuum. After this usage of vacuum, we need to ventilate the wound. And now we have a new ventilation methodology. That's the oxygen carrying sprays that's carry the oxygen on hemoglobin, particularly in the vicinity of the wound itself. So we can use something like Granulox to ventilate the wound itself and carry more oxygen to the vicinity of the wound, thus more supplying more oxygen, more ample ventilation to the wound itself until it reaches full granulation, and thus it is salvageable and functional. Another example is the healed wound that never heals. We still apply all what we have mentioned from revascularization. Here we have exposed all the calcaneus, then we can use the vacuum for 4 weeks, and then ventilated by Granulox till full granulation. Other examples are showing the same idea, not only in diabetic feet, not only in exposed tendons that we can use this and we granulate in diabetic feet vicinity, but also all non-salvageable wounds. If we apply the same technique, we achieve the same results with full healing and functionality of the wound. Even for venous aspect, we can apply the vacuum for venous ulcers. Such long-lasting venous ulcer could get 4 weeks of vacuum, then Granulox, it's completely closed and completely healing after years of non-healing. The message about this is that we are advancing in the field of vacuum therapy, advancing in the field of impregnation of the wound by oxygen in form of Granulox. Adding these two together, we mentioned what we are here for today. That's the advancement in tools, advancement in techniques, as well as also in lymphedema. We can apply vacuum, we can get better wound healing. This slide is meant to be left white and clear for the next year, where we will find more applications and more tools and much more mobile applications that could clearly judge the wound, clearly help in wound healing, and clearly the artificial intelligence is coming in real life. Thank you very much.
Thank you, Dr. Ihab. I'm sure this will incite lots of questions.
May I have the honor to present further beyond what I have said. That's new options for no option patients. I would love to present, with honor, Professor Giacomo Glerici, a known diabetic foot surgeon, member of the board of the International Association of Diabetic Foot Surgeons, a polyclinic of Abano Term, and Hospital San Carlo, Milan.
Thank you. Thank you indeed. May I use this one or this one? Is the same for you?
Yeah.
Yep. Yeah, okay. Perfect. Pointer. Okay, thank you. Okay. Ladies and gentlemen, dear colleagues, first of all, chairpersons, of course. First of all, let me thank the President, the members of the scientific committee for this kind of invitation, and in particular, a good friend of mine, Rashad Bishara, for these beautiful days in Hurghada. So, I do not have any conflict of interest to declare about this lecture, and I would like to share with you a clinical case we faced a few months ago about a 75-year-old type 2 diabetes patient with neuropathy, with pacemaker, hypertension, chronic kidney disease, stage 3, who underwent previous revascularization of the peroneal artery with Marco Manzi, Mariano Palena. I am very lucky because I am a foot surgeon and I work with the very three monsters in the interventional world field, Marco Manzi, Mariano Palena, and Roberto Ferraresi. But they found a very bad situation because this patient had a sad small artery disease with severe calcification, and they tried in April, but in May this patient still has a rest pain, but unfortunately with gangrene of the first and second toe. So rest pain with foot gangrene, prop to bone positive in the forefoot, and with these angiographic findings, you can see that we have a very, we call it desert foot without, if you look at in the right bottom, you can see even the perfusion is completely down. And the TCPO2 was 16 millimeters of mercury. So we thought about another option, so we published a few papers about the hybrid vein arterialization, but unfortunately this patient has some problem with the vein because he had a previous coronary artery bypass graft. And so a few weeks before visiting this patient, I met these two guys somewhere around the world in a conference. They talked to me about a new device, the transverse tibial bone transport with the TTT system. And I don't know if you are familiar with Elizarov technique with external fixation, with hardware or something like that. But this device is the rationale behind this device is that the tibial cortex transverse transport surgery is based on the Elizarov law of tension stress, which states that slow and gradual destruction of the bone activates and enhances the regenerative potential of living tissue. This is the surgical procedure, but we are going to see better in the next few slides. And summarizing, we can say that according to the Elizarov data, he started in the 60s, and after that in the 80s, he started to publish a lot about this procedure. We have a local response and, of course, a systemic response. And if you look at this paper, has been published in 2020, you can see that we have an increased blood perfusion and also an increased blood flow in patients who underwent this kind of surgery. So behind the science behind is that we have an increase of many molecules, many important actors in the wound healing process. You can see that the local responses we have the bone morphogenetic protein increase. P is a TGF-beta superfamily factor. We have an increase of activin type 2. We have an increase also of the hypoxia inducible factor 1 and vascular endothelial growth factor. So you can see that just in 8 minutes, it's quite impossible to sum up all the information. And we have also a systemic response with the mobilization of MRCS, the endothelial progenitor cells, also circulating cytokines level changes, and remote bone remodeling. So this is the device. You can see here, this is what you have in your operating theater if you carry out the surgery. From a surgical technique point of view, usually we use a peripheral nerve blocks. The corticotomy site shall be around 5 centimeters below the tibia. You can see here a metal guide plate with 2 holes at the center is inserted into the medial aspect of the tibial by 2 pins using the special TTT fixator as a guide to ensure the other 2 anchor pins for the external fixator are in the center line of the tibia shaft. 1 centimeter is skin incision. Usually we perform 6 incisions are made perpendicular to the guide plate, the slides as shown in this picture, and the corticotomy is created using a custom-made 3 holes drill guide. You can see that we can do the holes And after that, we check with the fluoroscopy the central pin position. Then insert the 2 anchor pins to keep the fixator in place and tighten all the pins and position the fixator well for patient comfort. The multiple drill holes are joined together with the scalpel, with the osteotomy. You must be very careful in order to avoid any fracture. And this is the time frame. The total duration of the treatment is 1 month and a half. You can see here, after 5 days, you start to upward the speed of 1 millimeters per day for 10 days. After that, 5 days of rest. And you, after that, put in the original position in 10 days with 1 millimeter per day the chip of cortex. So coming back to our patient, you can see that we started with this bad situation, 60 millimeters of mercury, rest pain with this foot. We carried out the surgery in the end of May, but you can see that in June we have an increase of the TCPO2, no rest pain. In August, TCPO2 increased a lot. Again, no pain, and you can see the second toe was almost completely healed and better with the curettage of the first toe. In September, this was the situation, and a few days ago, the doctor sent me a picture of the patient. So we started with this situation with this desert foot, and unfortunately, at the end, no, don't worry, it's okay. And you can see that with this very bad desert foot, we were able to achieve the goal. In particular, we were able to remove the rest pain in this patient. So this is the last literature. You can see 2020, 2021. We are at the beginning of the story because this is another option, another releaser option for patients with no options. And so if you are interested in this device, you can see that there is a lot of literature in the last few years. Thank you for your kind attention.
Thank you very much, Professor Kulerci. Very interesting technique. This will also incite lots of questions. Dr. Fedi.
I'm honored to present the next speaker, Professor Fedi Michel. Professor Fedi is a renowned orthopedic surgeon at Shams University. He's presenting his topic, Innovative Solutions for Difficult Diabetic Foot Deformities.
Good morning, everyone. First of all, thank you all for having me here. I'm not a vascular surgeon at all. I'm an orthopedic surgeon, works in Shams University, and I'm honored to work with the Egyptian Diabetic Foot Center team headed by our professor, Dr. Rashad Bishara. It was a great challenge for me to go through this field, the diabetic foot. It's well known that the orthopedic surgeon hates nothing more than infection. Infection for orthopedic surgeon means disaster. So Dr. Rashad invited me to invade this field, and it was my pleasure. Okay. In fact, diabetic arthropathy, this is the term, or the orthopedic term of diabetic foot or diabetic ankle. The diabetic arthropathy is a group of disorders of both bones and soft tissue that occurred in diabetic patients with peripheral neuropathy and loss of proprioception. It includes Charcot joint arthropathy, joint infection, joint subluxation, joint dislocations, and spontaneous muscle necrosis. In fact, the key of success for any diabetic foot surgery is a multidisciplinary team. And this is what encourages me to invade this field, that our team includes the very eminent vascular surgeons, diabetic foot surgeons, myself, plastic surgeon, endocrinologist, anesthesiologist, ICU team, and a very well-trained nurses. I will go to some cases directly. First, we tried the effect of joint fixation for soft tissue healing. It's well known in orthopedics that if you fix a mobile joint, the soft tissue over it will heal rapidly. So in such a case, this is a 52 years old female with extensive soft tissue infection of the foot and ankle. I fixed it with a very simple technique, a monoplanar fixator on the medial aspect, and our vascular surgeon did the debridement, and this is the result within 2 months after VAC therapy. The fixation accelerates healing, very good for soft tissue. It's another case, and this is very common, I think, in your field, the tendo Achilles infection. Loss of tendo Achilles resulted in equinus foot deformity and foot drop deformity. So after healing of the soft tissue, the patient will suffer much from this position of foot. He can't wet bear on a foot with equinus. So by a very simple technique, this screw, this is called Chan's screw. Sorry, I will. This is called Chan's screw. It's a very simple screw that's inserted from the heel upwards to the ankle joint, fixing the ankle joint in 90-degree position until the soft tissue heals. Once the soft tissue heals, the patient will have a plantigrade foot to walk upon, not an equinus foot. Also, the fixation of the ankle joint and subtalar joint accelerates the healing of the soft tissue over the tendo Achilles. Is another case of female patient who's 48 years old with extensive soft tissue infection around the heel. Her bone was totally normal. She has no disruption of the ankle joint or subtalar, but we just fix her with an external fixator to fix the mobile joint, and this was the result. Very good healing within 2 months by VAC therapy, and I think within 3 months she has good skin over her foot. Go to much more complicated cases, which is a staged strategy for management of infected, distracted ankle joint. This is a fact of our protocol in the center, that we usually, with infected, distracted ankle joints, we go for a staged operation. The first operation is debridement of the infected tissue, debridement of infected bone, prepare the bone surfaces for proper joint fixation and fusion, and we use at least the minimal fixation, temporary fixation of the joint. Minimal, temporary fixation for the joint. The second stage is wound care and wound healing, and the final stage is the permanent joint fixation and fusion. This was our first case. This is a female patient, 53 years old, has insulin-resistant diabetes mellitus. And she has a loose ankle, completely distracted ankle with very huge lateral ulcer, as you see. The bone also is exposed here with this infected ulcer, and the X-ray shows complete destruction of the ankle joint. What we did is that firstly, we do a lateral debridement for the ulcer, and unfortunately, in the same day of surgery, we were confronted with extensive soft tissue infection and abscess in the medial aspect also. So we have lateral and medial aspect infection of the ankle with complete destruction. We did a total debridement for the medial and lateral aspect, and we fix it with that Chan's screw also. This is screw, a very simple screw. And the patient goes for VAC therapy for 2 months, and this was the result. Both soft tissue on both sides were healed. Unfortunately, we have some superficial infection on the Chan's screw, so we remove the screw and continue with just cast, below knee cast, and continue until complete healing of the soft tissue. This is at the day we remove the cast. It's totally complete healing of the soft tissue. And we did a permanent fixation with these simple 6.5 millimeter screws. Did the patient foot after 3 months. This is the X-ray after 1 year. This is the patient walking with a very stable ankle with a very simple procedure. This is another patient, she's 68 years old. She has an ankle dislocation with huge, large ulcer, and the medial malleus is totally exposed from the medial wound and totally necrosed with infected, dead medial malleus and ankle joints. What we did is just excision of the infected bone, infected soft tissue. We just fix it with this very simple screw from downward, and we use a cast. This is the wound after we ended our operation. Follow-up of the wound with VAC therapy, till complete healing of the wound, then permanent fixation of the ankle joint, and this is a patient walking on her leg without any infection with a stable ankle joint. This is an example, this 46 years old female patient with failed fracture fixation. She had a POTS ankle fracture. She was fixed, and unfortunately it was infected and destructed and come with this ulcer and draining pus from the wound. We did our staged procedure, but we used the external fixator, monoplanar external fixator, with complete realignment of the ankle joint. And after healing of the soft tissue, a very simple procedure for permanent fixation. Unfortunately, 3 months later, she came with infected ankle fracture. So we removed the screws until complete healing of the soft tissue. We sure there's no infection. We refix her again with simple screws. There's another case with a 50 years old female patient had this plantar ulcer for 5 years now. It doesn't heal. By X-ray, she has a fracture at the anterior calcaneal process with equinus deformity of the calcaneus. The calcaneus is lying down like that in the ulcer, and the patient is walking on this pony prominence, so that she has a great ulcer here. What we did is, first we did a tendo Achilles lengthening. We did a tendo Achilles lengthening so can allow to realign the calcaneus. Simply inserted an external screw, the Chand screw from posterior to fix the fracture, and continue with the cast until complete healing, and then fixation with a simple screw, and the patient now has no ulcer for around 2 years. Conclusion, the multidisciplinary team is the key of success of such challenging cases. Case selection is very important. Always expect unhappy events. Simple procedures and simple implantation increases the rate of success. Thank you.
Very nice presentation. You'll be bombarded with hundreds of questions, Dr. Fadi. Thank you. So the next presentation is actually a recording from Canada. Dr. Perry Meyer is Chief of Diabetic Foot Clinic in Ontario, Canada. He's going to introduce this new technology of to treat diabetic foot ulcers using focused shock wave technology. Please run the video.
My name is Dr. Perry Meyer, and I'm the medical director of the Meyer Institute, a center of excellence dedicated to the treatment of diabetic foot in Hamilton, Ontario, Canada. And I'm here this beautiful morning to talk to you about DermaPace, which is a shockwave therapy used in the treatment of wounds. So PACE, or Pulse Acoustic Cellular Expression, is a proprietary form of extracorporeal shockwave technology. And this is a technology that utilizes high energy acoustic pressure waves in the shockwave spectrum created through an electrohydraulic method. PACE energy causes mechanical stress at the surface layer of these cells, and it's through this cell deformation or cellular cell wall stress that we believe the biological response comes from with DermaPace. So what is the mechanism of action? So PACE increases the local blood flow through angioneogenesis, which sounds sensible. It increases leukocyte transmigration through vessel permeability to allow these particular special cells to get to the wound bed to act on the medium. It increases cellular communication, so cytokine upregulation. So cytokines being the signaling elements that are bringing the necessary epithelial cells into the wound bed and are responsible for expressing the proteins that for growth factor production, for instance. And through this, it facilitates wound reduction and wound closure through granulation and reepithelialization via cell migration. So what are its indications for use? Well, in the United States, the FDA has cleared the use of DermaPace for the treatment of diabetic feet and diabetic foot ulcers. In the rest of the world, can be used for almost any type of wound. Diabetic foot ulcers, obviously, decubitus ulcers, ischemic wounds, venous leg ulcers, partial thickness burns, operative wounds, and post-traumatic wounds. So who is this for? Now, obviously for diabetics, the prevalence of diabetes is well known throughout the world. It is higher in certain locales, and certainly in the Middle East and Egypt in particular, the prevalence is high. And of those individuals with diabetes in the Middle East, 75% are uncontrolled. And of those, 25% will suffer a foot wound in their lifetime. And we know that those that go on to amputation, 85% of those are preceded by a diabetic foot wound. And unfortunately, the mortality rate is extraordinarily high amongst these individuals, and our mortality rates approaches 70% after 5 years. It's a tremendously high mortality rate. So what is our evidence? In 2007, there was a level one evidence. In 2007, a double-blinded, multi-center, randomized controlled trial was done. I was part of that. It was a very painful study to be part of because we had to enroll a lot of people, but it was randomized, double-blinded, and multi-centered. That put a lot of pressure on us, but the results were quite surprising and spectacular. It was found that 90% wound area reduction occurred over 6 weeks using this form of wound therapy. And what is most important about this pivotal study was that the inclusion criteria for these individuals included comorbidities that other clinical investigations would normally exclude. In 2018, the level 1 evidence was peer-reviewed and substantiated and validated. So these results are real-world results. These studies, the study results reported on demographic groups that are usually excluded from any of our diabetic wound studies. And we know the inclusion criteria, and these individuals fell well outside of those. These are true life subjects, obese patients. The average BMI for our patients was over 32. The majority of the patients had uncontrolled blood sugars with about 68% with blood sugar A1Cs over 7%. 50% of our patients were moderate to heavy cigarette smokers. And the care that they received out in the field, although was well-intentioned standard of care, it varied from locale to locale. But even with those types of patients, the results were spectacular. Now, level 2 evidence comes in the form of a study that was done by a colleague of ours, Wendy Cole, out of Kent State. And she was looking at extracorporeal shockwave therapy and how it affected tissue oxygenation in chronic wounds in people with diabetes. And what is important about her study is that she used the same study design that the pilot study was included. That being, it included the same population, the real world population. And in this study, she demonstrated an increase in tissue oxygenation, an increase in perfusion and capillary density, an increase in growth factors, and a 70% decrease in overall surface area after 5 weeks, but more spectacular, almost 50% complete closure in under 5 weeks in a certain subset of her patients. So let's take a look at how that affected perfusion, how dermaPACE affected perfusion in these diabetic wounds. Dr. Cole had 15 subjects with chronic diabetic wounds that had failed to achieve the standard wound area reduction after 4 weeks, that underwent 4 separate weekly treatments of dermaPACE. And then the tissue oxygenation was measured using near-infrared spectroscopy. And the reports were very encouraging. All of the wounds demonstrated a decrease in wound area, and almost half of them completely healed, all within 4 weeks. And most significantly here is that all wounds displayed a statistically significant increase in tissue oxygenation. This is a tremendous effect from this treatment modality. So what is our clinical case evidence? So we're going to take a look at a few cases demonstrating the effectiveness of dermaPACE on chronic wounds, generally underperfused, but are in a chronic stalled state. So this is a patient from the pilot study who was one of my patients whom we had been treating for many, many months prior, went on to distal ischemia with distal gangrene and multiple toe amputations. The middle 3 toes were amputated last, and they resulted in an open wound that was not closing with standard of care and advanced wound treatment modalities. This patient received dermaPACE and over a 15-week period had complete closure. And this is in context of a patient like this who was really not progressing over many, many months, at least 12 to 15 weeks prior, that had the wound restarted and go on to complete closure. Now, this is a paper that we produced for Wounds Canada in 2020, I believe, and it demonstrated the effect of dermaPACE on incision line healing and peri-wound edema reduction. And we found that that the healing time for annealing of the incision lines was cut in half, and the wound area, the peri-wound edema reduction was significant, although we had no real way to measure that except for subjective measures, which we reported on in the poster. And finally, this is a wound that was managed by a great colleague of ours in San Antonio, Texas, Anna Sanchez. And this is a heel wound, which we all know are very, very problematic in healing. It had been, Anna had been struggling with this for many months prior. And she then embarked on a weekly course of dermaPACE. And over the next 9 weeks, from the picture on the left to the one on the right is 9-week span. She had a 75% wound area reduction, but what is significant is that the morphology of the wound is completely different in the picture on the right, with a very superficial, easily healed wound, which is well on its way to closure and has a very positive healing trajectory. And this was all as a result of the introduction of dermaPACE and nothing else. So these are very compelling results. So in conclusion, we want to talk about the challenge of wound healing and where we focus our attention. And wound clinicians in general typically tend to look at the surface of the wound when really we need to look below the wound bed. We need to look deeper into the wound and see whether we can manipulate those elements to help us heal these very problematic wounds. The problem lies below the wound bed at the microvascular level. And dermaPACE, we've shown, is a proven focused technology that reaches below the wound bed surface to treat that microvasculature, to manipulate it and promote it, to allow it to proliferate and nourish the wound bed, not only with blood flow, but with the other elements like cytokines, growth factors, etc. I thank you so much for listening, and I hope that this has stimulated your mind to utilize this treatment modality in many ways, but it is a versatile technology that really has just scratched the surface, and we want to go beneath that surface. I hope that we can have a discussion later. If you have questions, I'd be more than happy to speak to you about them. Thank you again.
Yeah, interesting technology. Dr. Meyer, unfortunately, cannot be with us because it's 3 a.m. In Canada. So we can write to him questions, maybe.
Now it gives me a paramount honor to present Professor Dr. Rashad Bishara, the head and the founder of the Vascular and Endovascular Surgery at the General Organization of Teaching Hospitals and Institutes. Dr. Rashad is also known being the founder of the Egyptian African Venous and Lymphatic Association, EVLA. Please, sir, waiting for your kind presentation.
Once again, thank you, Professor Nasser Said and the organizing committee for the privilege. It's my great pleasure to be here. I'm going to talk about something that might look a little bit boring, and that is painful neuropathy. I have no disclosures related to this particular presentation, and why should I talk about neuropathy to a community of vascular surgeons? Because neuropathy is so common. It affects 21 to 25% of our patients, and in our practice, a full 24% of the patients come presenting with this mainly. Obviously, it affects their quality of life. They are unable to sleep. It gives a lot of foot pain, pins and needles, and numbness, and maybe that's because why they come to us, vascular surgeons, because they don't feel their feet and they think it's bad circulation. And of course, we all know neuropathy predisposes to ulcers. I'm not going to bore you with this complex pathology, but painful neuropathy could appear before the diagnosis of type 1 or type 2 diabetes. The standard treatment, as documented in the British NICE guidelines, is glycemic control and medications, anti-epileptic medications, and antidepressant medications in stepwise manner. The majority of patients who come to us have already experienced these medications, and it failed to control the symptoms. So I'd like to introduce to you to this relatively new technology, FREMS. FREMS is Frequency Rhythmic Electrical Modulation System. It's a non-drug option to treat the pain of painful neuropathy. And it consists of a series of electrical currents, electrical stimulation. It produces electromagnetic waves, the objective of which is to alleviate the pain of painful neuropathy. What's the clinical evidence? There has been 4 studies, about 151 patients, 3 RCTs, and 1 case control studies. All the studies used the same device, and all of them were performed in Europe. And this is the most important one of which. It consists of 110 patients which were randomized into FREMS versus placebo. And you can see from the charts here, the first chart on the top is for night pain, and the bottom chart is for daytime pain. The white dots are for the placebo, while the black dots are for the treatment group. So as you can see, that's before treatment and that's after treatment, and that's week 12, 24, 36, etc. This is the group who had placebo, and this is the group who had FREMS technology, and there is a significant difference in pain between the 2 groups. So there is significant reduction in pain in the FREMS group, both at night time and at daytime. And accordingly, this technology was accepted in the British National Health System, and this is the statement: Aptiva, which is the FREMS technology, would be used in addition to or as a replacement for pharmacological treatment if this fails. So this is our experience with the FREMS technology. We reviewed our experience in the past 3 years, from January 2019 to January 2023. We included patients if they were 18 years or older, if they have painful neuropathy or severe numbness, they couldn't feel their feet, and they had diabetes that's diagnosed and documented for greater than 1 year, and they were on stable neuropathy medications, which I just described, for a minimum of 6 months regularly, and they had an EMG showing diabetic polyneuropathy and documented absence of ischemia, peripheral ischemia. We did not include patients who had ulcers or who had pacemakers, because this technology could interfere with the function of pacemakers. The FREMS protocol is quite simple. 8 electrodes are applied to the skin of both legs, and the therapist increases the electrical dose until the patient feels the pulses, but without feeling pain as a result of the pulses. The treatment continues for 35 minutes and is repeated every day for 10 successive days. And we measured the results according to a visual analog scale. So a score of 1 means no pain, a score of 5 means severe pain. We explained the visual analog scale to the patients, and we asked them to assess their own pain every session. We used the same score for numbness, and we asked the patient to assess his own numbness according to this scale in every session. And these are the results. So it's a 3 years retrospective review. It included 321 patients. The mean age was 57, 59% were male, and 223, that's 69 of the patients could respond adequately to the visual analog score. The other patient did not understand or did not respond. And these are the results. And as you remember, 5 is the maximum. So 5 is very severe pain. And this is the average pain score. So initially, the average pain score of the whole group was 4.7. And in the session number 10, it was 3.1. And I'd like to remind you that the minimum is 1. And again, this is the percent of patients who scored 5. That's severe pain. So 81% of the patient perceived severe pain at the beginning of the treatment, while at the end of the treatment, only 10%. And to our great surprise, and this is not documented in the literature, this technology also improved the numbness and the feeling of anesthesia in the periphery. So at the beginning, again, there was severe anesthesia. This is the average, I would say, numbness score, and this is the average numbness score at the end of the 10 sessions. Again, those patients perceived their numbness as very severe, so 82% at the beginning, as compared to 11% at session number 10. We also asked the patient at the end of the treatment, we asked the patient to score how much improvement did he feel in his pain or his numbness. So a few patients said 0, no improvement, and a few patients said completely gone, the symptoms, but the majority of patients fell between 40%, 50%, 60%, and 70% improvement. And the average improvement for the whole group was 51%. So this means if you ask the patient, how much improvement did you feel? The average was 50%. And there was no side effects at all. And this is our conclusion, that FREMS technology proved to be safe, and it's effective symptomatic treatment for the majority of patients presenting with painful neuropathy. And currently, we are doing a long-term study to see how long the improvement continues. Thank you for listening. It's my pleasure to introduce Dr. Alexander Lazarov for his second presentation, Computer Vision Strategy and Applications in Medical Practice.
Hi, everybody, again. The AI story is about to continue. We are about to comment on and discuss the computer vision as application in the medical practice. So let's start with the essence of the computer vision. It is a purely virtual data exchange activity which is dedicated to monitoring of targeted, quickly moving objects or fast developing processes, extracting data from them and developing a mathematical model. Further comes data manipulation via mathematical processing to explore possible outcomes in diverse conditions. Then comes hypothesis generation of predictions and their performance. And the most challenging feature here is that apparently AI is already automatically memorizing its experience. It's a great debate whether this should be recognized as knowledge or not. Something very essential here regarding medical diagnostics, as far as the activity is entirely related and limited to data exchange and information exchange, this means that unless there is some robotic periphery involved to intervene, in any event, the AI does not bring any risk to your patients. Here are the principal methods which computer vision applies. First, this is single or multi-spectrum monitoring, image outcome overlap, and comparison. Second comes finite element mathematical analysis. And third is, in cases of figured out self-similarity, calculating the coefficient of diversity. In a minute, I'll give examples from the three methods to better understand them. And you must know that they may be applied individually or sometimes in a set. So, what is the strategy? What is the benefit from applying computer vision? First of all, it discloses invisible processes and activities that we don't know. Second, it recognizes many details and peculiarities within these advancements that we humans cannot do. Remember the example of iris recognition. Then, computer vision produces the estimated process development and allows its influencing by mathematical means to explore various options. And essentially, it allows numerous runs in time, forward and backward, so you can test various experimentations on how to influence the outcome. And finally, before the examples, I want to spare a minute about the diversity between AI and the computer program as far as computer vision is exploited also by some computer programs. If a software expert has to develop a computer program, it contains a lot of rules, laws, procedures, orders, etc. And his mission is to tell the computer system, run from stage A to stage B. And depending on the result B1, then proceed further to C1, B2 to C2, B3 to C3, etc. However, in case the software did not predict any possible outcome, the program blocks. Example, you receive a letter that is written under a Microsoft Word program, but you don't have installed the necessary font that the letter was written in. So in this case, you have on the display only some symbols that you cannot understand or some simply squares. This is the program blocked. So now, here are the examples. The first one is dedicated to venous disease treatment and to an investigation what is the blood tension that the vein valve and the vein can hold. The idea is to introduce a time component, so both the medical expert and the patient will know how long the surgical or other intervention can be delayed. It is a project under development at the Bulgarian Academy of Sciences Mathematical Department, and my wife, who is a vascular surgeon, and Dr. Elena Goranova, she is sitting here, is involved to this initiative. Here you have the finite element analysis example. This is the case of abdominal aneurysm examinations and the rupture risk assessment. All of you know how important it is to be aware whether you have to run immediately to the surgical room once your patient has arrived, or you have some time to get prepared, etc. So on the right picture you see black squares of black net, and each piece of that is a finite element that is mathematically studied individually and in a set with its neighbor. So the prediction is developed. What is most substantial for the finite element exploration is the image resolution, because the higher the resolution is, the number of the net pieces is greater, and therefore the probability of the prediction is much, much higher. Here is something that is directly related to the topic of this session. This is the computer image exploration of diabetic foot. In this case, AI applies red, blue, and green visible spectrum imaging in a set with infrared, the thermal spectrum, and the images comparison and overlap allows to make a prognosis about whether ulcers will appear and how soon this will happen. And finally, this is a very challenging approach. This is the calculating the coefficient of self-similarity. I have to introduce Benoit Mandelbrot, a famous mathematician who was employed by IBM for longer than 30 years last century. Mandelbrot claimed and proved that classical mathematics cannot deal with self-similarity because it deals with uniform units, while he developed the fractal theory, saying that self-similar pieces that seem similar but are not equivalent can be studied by calculating the coefficient of the diversity. Example of fractals are the leaves of a tree, the drops in a cloud, the cells in any biological organism tissue. So what's the benefit? Once you examine such a tissue, let's say human lung or some other organ, in case in some area this coefficient comes out to be diverse than the general one, this already means that there has started a degenerative process. Thanks for your attention.
Thank you, Dr. Lazarov.
Again, it gives me a great honor and pleasure to re-invite Professor Giacomo Glorici for a wonderful presentation entitled Tips and Tricks in Food Surgery After Foot Vein Arterialization, a New Concept in Food Surgery.